Hello, everyone, and thanks organizers for this wonderful opportunity. We'll be discussing neoadjuvant and adjuvant treatment strategies in renal cell cancer. So, firstly, talking about the neoadjuvant systemic therapy, it's vastly an unexplored field. It is not a standard of care in localized RCC. However, there are some theoretical benefits, such as cytoreduction as a result of NACT, could allow for the partial nephrectomy or ablative techniques in patients who are poor surgical candidates or tumor downstaging to achieve resection of locally advanced, previously unresectable tumors. Also, early systemic therapy could eradicate micrometastatic disease and reduce recurrences rate. It can also allow for the correlation of treatment with pathological responses and immune responses. There is not much data of various drugs, especially for the TKIs. There was one phase 2 study of neoadjuvant axitinib in 24 patients, which demonstrated a median reduction of 28% in the primary tumor, with 46% of patients achieving partial responses. Another study in 18 patients reported a median reduction in the primary tumor of 17%, with 25% of patients experiencing a partial response. Thus, neoadjuvant VEGF TKI is feasible and induces downsizing of the primary tumor. What about immunotherapies? So the immunotherapy data is very early, and it is actually extrapolated, or what we can say is that it comes from patients who have had the surgery for the primary tumor and also for the metastatic disease. So this was one such 3-arm trial where nivolumab with or without bevacizumab or ipilimumab before surgery in treating patients with metastatic kidney cancer that can be removed by surgery. So patients were given treatment, nivolumab plus bev or nivolumab plus ipilimumab. And after 4 to 6 weeks of the treatment, cytoreductive nephrectomy and metastatic removal was done. And then there was maintenance nivolumab. So we don't see much advantage of addition of bevacizumab or ipilimumab in the nivolumab arm. Meaning by that, we still need to find out patients who are benefiting from neoadjuvant therapy. We have to find out subgroups where the combination therapy also might work. Another important consideration in NACT is that you have the traditional endpoints such as survival outcome, safety, quality of life being latest in the list of outcomes, but also PAT-CR rates and ease of resection. So here there was a small retrospective series of 11 patients who received immunotherapy for the metastatic RCC and achieved a pathological complete response, then underwent cytoreductive nephrectomy. However, the surgeons reported difficulty in finding dissection place due to adhesions and inflammatory reactions at the kidneys and its surrounding tissues in 9 out of these 11 patients. So we are targeting ease of resections in NACT, but sometimes this might not be possible in spite of achieving pathological complete responses. So these are unanswered questions in the sense that whether neoadjuvant or the adjuvant immunotherapy is a better approach for localized RCC. A lot of trials are coming up for immunotherapy in NACT and the results are eagerly awaited. There is a theoretical advantage of neoadjuvant immunotherapy because the PD-L1 blocker results in situ expansion of tumor-specific T cell clones already within the tumor microenvironment and may also act at the tumor draining lymph nodes to enhance the production of tumor-specific T cells there as well. So you may get a robust immune responses with the tumor there rather than using immunotherapy in the adjuvant setting. Also, it leverages higher level of endogenous tumor antigen presentation in the primary tumors to enhance T cell priming. There are also studies which are doing immunotherapy in the perioperative setting. So that we will also know that how much is the advantage of addition of NACT and continuing them in the ACT. So take-home pointers are neoadjuvant trials with immunotherapy are ongoing. Endpoints of neoadjuvant trials should assess tumor shrinkage, surgical feasibility, long-term disease-free and overall survival benefit, and exploratory biomarkers to understand predictors of responses. Although no head-to-head neoadjuvant versus adjuvant clinical trials are ongoing, there is a strong biological rationale to treat with immunotherapy with the tumor in place. Now, what about adjuvant therapy? The standard treatment for RCC is surgery followed by observation. There are certain high-risk scores to predict the higher recurrences. So risk predicting scores which take into account the stage, tumor size, symptoms, histological subtypes, also performance state of the patient, grade of the disease. And then because necrosis is now established as a marker of high aggressive disease, some predictive scores are also taking that into account. We have now genetic signatures or gene panel analysis, which reveals a better the risk predicting scores. So a lot of work for the risk prediction and maybe the further adjuvant, further the studies progress, further we will see more and more adjuvant trials being decided based on these scores. But as of now, especially for advanced stage T3, T4 or lymph node positive disease, we see a lot of patients coming up with recurrences. Around 30 or 50% might recur after surgery. The recurrences rate might be for the localized disease, or if the patient has undergone complete removal of the metastatic disease, there also recurrences are possible. The journey of adjuvant treatment started from studies of cytokines, which did not reveal much benefit. And now there are few studies for the TKIs, and latest in the addition of immunotherapy, especially pembrolizumab. So sunitinib was the one drug which was most commonly used in the metastatic first line setting, and that it was the drug which was tried in the adjuvant setting. We had Assure trial and Extract trial, mutually conflicting results from these trials. The Extract was actually a positive trial. The primary endpoint was met. It showed a DFS of 6.8 versus 5.6 yes, for sunitinib and placebo respectively, and HR of 0.76. In Assure trial, which was actually a larger trial, the primary endpoint, which was DFS again, it was not met. So why was this? Why do we see that there was a discrepancy in these results? Now, one reason could be that in the Assure trial, patient with T1B, which is very early stage patients were taken, provided they had higher grade of disease. Such early stage patients were not allowed in the Extract trial. Second, the lowest possible dose in case of side effects was 25 mg in Assure trial, which was just around 37.5 mg in the Extract trial. So lower is the dose. We understand that it might have a bearing on the overall outcomes. Also in the Assure trial, patients who had, like, it was not just the clear cell histology, but non-clear cell histology patients were also taken. We understand that sunitinib might be more effective in the clear cell subtype. There was one important pointer that in Extract trial, patients who had microscopic residual disease were allowed. So in Extract trial, they took patient with R1 disease as against Assure trial. Also, we see more treatment discontinuation in the Assure trial. So I do see that I would say that they were high. For adjuvant trials, patients don't have disease-related symptoms. Hence, any treatment-related side effects have a strong bearing on the treatment continuation. So we do see a lot of discontinuation rate in both the trials, but it was higher in the Assure trial. So maybe all these factors impacted the results of these trials. There was one more meta-analysis which took the trial level data, not the patient level data. And it took the results of all these two trials. It again overall showed that there is not much benefit of adding this adjuvant TKI, and the HR was more than 1. So overall, maybe because of the side effects or for various reasons, we still have to find out what is the best possible adjuvant TKI. We do understand, and there's still lack of clarity on what should be the duration of TKIs. We might be just delaying the recurrences rate and not just preventing it. So other trials for sorafenib, pazopanib, and axitinib has also been done, but they have not again conclusively showed benefit with the TKI. Now, what about patients who have a complete resection of metastasis? For sorafenib, we have RESORT trial. So this was a histologically diagnosis of predominantly clear cell RCC patient subgroup. Maximum 3 metastatic lesions were allowed, and no more than 3 months from the radical resection of metastasis. So patients were randomized in 1:1 manner to sorafenib and the observation arm, and the sorafenib was given for 1 year. The primary endpoint being RFS. And we don't see any benefit of adding sorafenib. And we understand sorafenib is a difficult drug. We have a lot of hand-foot syndrome and other side effects with sorafenib. And there is not much benefit. So sorafenib is actually out of usage in this particular setting. Now, what about pazopanib? So this was a randomized double-blind phase 3 trial of pazopanib versus placebo in patients with metastatic RCCs who have no evidence of disease following the surgical removal of metastatectomy. Pazopanib was given again in 800 milligram, the standard doses with 52 weeks of treatment, and it was compared with the placebo group with the endpoint being DFS. And we don't see much improvement in the disease-free survival group. 36 months of the DFS was pazopanib arm was 26% compared to 22% in the placebo arm. And we understand that pazopanib again is not a very easy drug to give. So a very teeny tiny marginal benefit. And yes, at the expense of a lot of side effects of pazopanib, especially liver problems. Now, what about immunotherapy? So Keynote 564 is the trial adjuvant pembrolizumab versus placebo after nephrectomy for renal cell carcinoma. Now, the beauty of this trial was that it not just took patients who had localized disease, but they were also patients who were had metastatic disease, provided the metastatic the surgery for the metastatic disease was Done. So pembrolizumab 200 milligram for 1 year was given once in 3 weeks. And the primary endpoint was DFS. So the baseline characteristics were fairly balanced, and around 14 to 15% patient had ECOG performance status of 1. Patient who had M1 disease were around 5.8% in both the group, with no evidence of disease after the surgery for the metastatic disease. Fair balance from many parts of the world, and we do see that they also did the PD-L1 testing from the CPS score. Around more than 70% patient in both the groups had CPS score greater than or equal to 1. And around 10 to 11% patient had sarcomatoid feature, which we understand are high risk for recurrences. So as far as the DFS is concerned, the drug favored better compared to the placebo group, with 12 at both time points of 12 months, where the DFS rate was 85.7% in the pembrolizumab compared to 76.2% in the placebo group. And at 24 months, it was 77.3 versus 68.1. So hazard rate of 0.68 and p-value of 0.001. So, and we see if this important subgroup analysis, we see that the pembrolizumab fares better compared to the placebo group in all the important subgroups, such as age, irrespective of sex, performance status, PD-L1 status. So that is why we, in the clinical routine practice, we don't do PD-L1 testing in RCC. It does not have bearing in the treatment decisions. So similarly, the pembrolizumab results are also irrespective of the PD-L1 status. And importantly, the results were quite good in the M1 NED setting. The interim analysis is too soon to say, but we do see a signal of benefit in, again, the pembrolizumab arm compared to the placebo arm with HR of 0.54 and p-value of 0.016. We are well aware of pembrolizumab side effects, but as I previously said, in the adjuvant setting, because there are no treatment-related symptoms, there are no disease-related symptoms, we should have less of treatment-related side effects also. So grade 3-4 fatigue, diarrhea, and rash observed with pembrolizumab. However, no deaths occurred in the study. Median duration of treatment in pembrolizumab arm was 11.1 months. The important thing is that we understand that a lot of side effects are because of the immune-mediated reactions, and use of steroid is also needed in a subgroup of patients. So around 7.4% patient needed use of high dose of systemic corticosteroid treatment for immune-mediated adverse events. Grade 3 or 4 immune-mediated adverse events were uncommon. And the important side effects were in terms of hormonal dysfunction, thyroid problems. Some patients had pneumonitis, adrenal insufficiency, type 1 diabetes, colitis. But overall, all these side effects were promptly reversible, and yes, either with treatment interruptions or with the usage of steroids, and there were no deaths due to these immune-mediated adverse events. So in the first pre-specified interim analysis of the phase 3 Keynote 564 study, the adjuvant pembrolizumab achieved a statistically significant and clinically meaningful DFS improvements in patients with RCC post-nephrectomy, and HR of DFS was 0.68, and DFS benefit was consistent across all major subgroup examined, including patients with M1 metastatic staging and no evidence of disease. Overall survival data is still immature, and safety profile with pembrolizumab is consistent with previous reports. So investigator concluded that the pembrolizumab might be considered as a possible new standard of care for patients with RCC in the adjuvant setting. So many trials are still ongoing, and I would say the results are awaited. So just to conclude, optimum strategies in the neoadjuvant setting and the adjuvant setting are lacking. Importantly, for TKI, side effects and the lack of clear-cut benefit makes them less favorable. Immunotherapy seems promising, and the results of ongoing trials are encouraging. Thank you.